Simon Fernandez. I am the founder of the HeartFit Clinic. I'm also the author of the book Beating Heart Disease and author of the new book coming out, Death of the Stress Test. And, you know, we always talk about some important gaps that we talk about filling in the healthcare system when it comes to preventing and reversing heart disease. And so when we look at the aspect of heart disease is the number one cause of death of men and women. It's jumping between that and cancer, but it's the number one preventable disease. And I had the fortunate privilege of meeting Dr. Oscar Aguilar at a conference here last month, I think, or earlier this month. And we had a really great time, and we were talking, and I'm like, man, this is the level that everybody should be at. And so I'm going to welcome Dr. Oscar with you. And Dr. Oscar, maybe I'll let you introduce yourself and where you're from, and a little bit about your background quickly.
Yes, absolutely. A pleasure being with all of you here. Originally from Mexico, did medical school. Then I trained in internal medicine, then cardiology, then interventional cardiology, then nuclear cardiology, then advanced cardiac imaging, and then a master's in public health. So with all that, I came back to Texas to establish my practice with a very busy cardiology group, great group, where I started, hitting the ground running, very busy from day number zero, operating hearts, which was my passion since I was a kid. I always wanted to be a cardiologist. And every day I had at least three, four, sometimes five surgeries of the heart. And later on, I did clinic, seeing all the way from 20 to 35 patients in clinic. And this was pretty much on a daily basis. Very happy doing what I always wanted to do, and hopefully making a difference for some people. But then as time went by, going into like 10, 12 years of doing all this work, I was a little bit intrigued of if I was really making a difference or not, because a lot of the times when I did a heart surgery, I ended up doing another surgery on another vessel on the same patients, different area of the heart. Now I started doing surgeries in the arteries of the legs, arteries of the kidneys, arteries of the arms, arteries of the neck. And I was like, wait a minute, I don't think I'm catching up with the disease. And we have a lot of diabetes, high blood pressure, obesity. We have a lot of a sedentary lifestyle. And the kind of food that we eat in the United States and pretty much all over the world is pretty bad, very unhealthy. And that's a major problem because a lot of times we are told that it's healthy and we eat something that we believe is healthy and it's completely the opposite. But as a physician, sadly so, we hardly have any training in nutrition and we hardly have any training in prevention. So I was first uh, looking at that reality and I said, there must be answers somewhere. So I looked around and I ended up doing another specialty in obesity this time. I did not think it was enough because I still wanted to learn nutrition. So I found the American Anti-Aging Medicine Association. I also find the Institute of Functional Medicine. These entities, these groups are backed up by science, by well-known universities like Washington University, like University of Central Florida. And so I decided to do additional training. And finally, I did metabolic medicine
Mhm.
and nutrition, something that I never really heard about when I was in med school, even though I went through a lot of training. After that, I did hormone replacement therapy training. After that, I started applying all this knowledge into my practice, regular practice, operating hard, seeing patients in clinic, like I described from the beginning. And what you realize is that within days or weeks, there are many important changes in the health of people. And as long as they are willing to make changes to their lifestyle, diet, exercise, and so forth, there's a huge impact in health. So that really, really changed the way I would see and perceive medicine. I felt that I was patching hearts, but not improving anything else. And then I kept patching hearts and patching hearts. My favorite surgery used to be that one that came through the door dying, patient with a heavy, huge heart attack. that if I did not open a vessel within minutes, the patient would die. That was my favorite because I would like the stamina, the uh, the adrenaline, sort of like the emergency of the case, and that was my favorite surgery. But then I realized that to get to a heart attack, you need at least 15, 20, 30, maybe 40 years of bad nutrition, lack of exercise, diabetes, prediabetes, metabolic syndrome, you name it, until one day the plaque ruptures and give you a heart attack. So if I could impact the life of my patient 10, 15, 20, 30 years before, then I would avoid or prevent this patient from having a heart attack. And that's now my world. So
Hmm.
with the pandemic, I stopped doing heart surgeries pretty much in 2020, like around March was my last one. Precisely, it was a heart attack. Then during the pandemic, we could not go to the cath lab and do up where we do the heart surgeries. So I don't know. It came together, and I was said, you know what? That's it for me. I'm going to dedicate to hopefully prevent these problems and to change the life of a person, not by patching a heart, but hopefully changing the whole aspect of health. And here I am seeing patients in Texas, brick and mortar, a clinic, we call it the concierge service. I only see now 600 patients, but I have a partner, Dr. Menento, and we are trying to put together a service, online service, to reach out more people that are wanting, willing to do
Hmm.
to make changes in their life to get to the point of being very healthy and live not only longer but better.
Yeah. I love it. I mean, and that's why, obviously we're working together and we want to, obviously have you reach your goals. And I really find it's very valuable. Like just for our listeners, I'm going to share my screen very quickly. And the reason why I wanted to share my screen very quickly is just so people can see when I talk about, and probably have seen this many times, is that, when we look at artery disease, I don't know if you can see that here very well, right? It's not a I say this 1,000 times, but it's not a pipe. And you just talked about it like this is what you did for a living for many years is open up that clogged pipe. And it's not a pipe, it's a muscle. And there's a lot of biology that happens to this lining of the muscle. So where Dr. Oscar comes into play is that if you're having a heart attack, we want to get you to do that angiogram right away, see where that plumbing problem is. And this is what you want to be in the hands of an interventional cardiologist like yourself, right? When you're having that problem. But, then you get that heart stent or bypass surgery and, I've heard lots of great things about how you are in the cath lab, and that's good stuff to be able to do. But if you're trying to prevent it, going to your family doctor and cardiology, they don't do a good job to prevent it. And how you prevent it is not by doing angiograms, which is where our thinking was in the past, is like, oh, let's go do angiograms and see where that plumbing problem is so that we can see what's going on. And so this is where, I really enjoyed the conversation I had with you is that, look, the cath lab, which is where it saves lives. Like you talked about it saves lives if you're having a heart attack. That was your specialty for many years. But going to the cath lab now, if I can ask you the next question is that this is not what we do to prevent heart attacks anymore. Can you talk maybe about the trials that have come out and how it supports where it's being used to see a cardiologist versus someone now like yourself who's switched and gone to the prevention side of things? Talk about how cardiologists don't really do prevention.
No, no, not at all. Zero prevention. And that's where I was about 12 years ago, facing myself with the fact that we do not learn prevention or nutrition or any aspects of prevention in medical school. And I said, when I finished medical school, I said, well, but I'm going to be an internal medicine doctor, so I'm going to learn this at some point. Zero. Then a cardiologist, less. When I became an interventional cardiologist, I was operating hearts the whole day there for a whole year. So you don't learn prevention or nutrition, which is pivotal when we're trying to prevent a problem. That's the way to start. There are many ways along the way. There's many other factors, but nutrition is crucial. So no, a cardiologist is not there to prevent. I hope we can change that later on. But
Mhm.
as you were talking, I think you nailed it down. we need to make sure that we understand the very fine distinction. Acute care, you're having a heart attack, you're having angina, you need something done right away. And United States and Canada are great places to have those things done. But when it comes to chronic problems, those things that do not require an operation, that they require more lifestyle changes, prevention, ways of doing things right, we are pretty bad, in bad shape in both countries, pretty much all over the world. So, correct. You go to the cardiologist to help you with some ongoing problems that were not prevented. You're already there. But if you want to prevent the problem, whether you never had it before, we call it primary prevention, or where you already had a problem in the heart and now you need secondary prevention, you need to find a doctor, a service like the Heart Fit Clinic, where they know exactly what to do to have that problem at bay, meaning not to come back or never have it as a problem. After a heart attack, heart attack ends up killing a piece of the heart. It could be small or it could be large. It actually can kill you and just, go straight to another world. But that little piece of heart that dies is not going to work anymore. And then you can end up with heart failure. And heart failure is hard to live with. You need to take a lot of medications. You need to be very careful with many things. And it gets to the point they say, well, what if I would have done things better 10, 20 years ago? And and I don't care if you're 20, 30, 40 and you never had a heart problem, or you're 70 and you already had other heart problems. There's always a good moment to stop, pause, get answers and help from a clinic that helps you prevent these problems from coming back.
Mhm. The idea is when you look at when you go to a cardiologist and you're trying to prevent a heart attack, and so this is what my next book's about, and we talked about it earlier this month, is that it's called Death of the Stress Test. And I'm going to just talk about this quickly, is because it sounds like I really hate stress tests, and I don't. I hate the outcomes. And the outcome is that, hey, everything's fine, and I saw the top of the world of heart health, and I got a clean bill of health from a cardiologist, and I've seen this in the 26 years that I've been doing this. How many people have had a stress test and still end up with a heart attack or a heart problem? Before we get into that, can you comment on why that happens? Like, just what's the
Yes.
concern there?
In fact, let me share something on the screen, if I may,
Absolutely.
because yeah, I think he'll help explain that point, which is a very important one. Okay, can you see it now?
I think I can see it. Yes.
Okay, so this is a vessel. Can you see my mouse
Yes, we can see
pointer?
your mouse. Yeah.
Got it. So this is a vessel, and this is what it looks like normal vessel, and slowly we can see the progression of the plaque. Now, this is not the way it looks inside the heart. Inside the heart is there's a huge disarray of the structure, but to make it easy, this is a normal artery, and unfortunately, these normal arteries do not last very long in the United States or Canada. Soon enough, maybe like around 20, 25 years of age, we already have these amount of plaque. And the plaque can grow fast, can grow slowly, but at any given time, it can give you a heart attack. It can give you a heart attack when it's not obstructing any flow, when it's obstructing perhaps half of the lumen, we call it, of the volume of the vessel, when it's obstructing more or more. It has to rupture in order to give you a heart attack. So the problem is this. I always ask my patients or my students, if I were to do a stress test here, when the obstruction is around 50, 60% of the blood flow, how do you think the stress test is going to come back? And everybody says that it's going to be abnormal. And that's not true. If you have a stress test at this stage, stress test is going to be normal. Let's say that you add nuclear imaging, which, I have a specialty on that. Or let's say
Mhm.
that you do add PET scan imaging, which is the latest. And I also read those studies.
Which is also a lot of radiation and
There's a
radioactive
lot of
dye. Yeah.
radiation, and
Yeah.
the stress test is going to come back normal as well. So you don't detect any significant amount of plaque. I'm going to go to the next slide. Let's see where it is. There you go. This is the vessel again in longitudinal way, and this is the same vessel at transsectional way of the cuts. So everywhere along the way of this plaque, the stress test is normal, 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 normal. You don't get to be abnormal until you get here. So it's like, wait a minute. So, so what is the stress test doing? Is detecting this significant blood flow problem where the patient is expected to have symptoms, chest pain, shortness of breath, and you name it. And that's when we, cardiologists, intervene and put a stent because now you need to open the vessel. But all these things go undetected. And at any given time, here, or anywhere, you can have a heart attack. And that's what happened to Tim Rosser years ago. Some of you may remember this guy, Meet America, was, I think, in NBC. The guy had had like 30 or 40 days before a clean bill of cardiology health. He was on great medication, supposedly, and his
Mhm.
stress tests with nuclear imaging came back normal. But before he started the news, he died suddenly on his desk. Well, that's the reason. Those tests, I don't care how great studies there are and what the latest is, they are not going to detect all the plaques, and any given plaque at any given point, at any given size, can give you a heart attack. So, as you were saying, you know, it sounds tragic, but the death of a stress test, we can make a case that says, wait a minute, that's not the way to detect disease. Way to detect disease, if we're interested in detecting it soon, is by doing what we call a calcium score. And you can do a CT scan and take pictures of the heart to find out if that patient already has some plaques building up, and then work on reversing them. I don't have a picture of the calcium
I might
score.
have one, yeah. I might have one here if that's
Okay, okay. So I'm going to
yeah.
stop sharing now, and that's an early way to detect disease. But there are others that we can do. Uh,
And when and just going on, I think let me just get to that slide there. But when you talk about a calcium score, to me, so I'll give you actually a really great scenario that just happened very recently. I had a patient who had a 0 calcium score and had a 70% lesion that was non-calcified.
Correct,
And they were getting
correct.
symptoms. They were getting symptoms. And they're like, well, you had a calcium score, it's clean. So and then they ended up doing a CT angiogram, which is a virtual angiogram to see what's going on. But this person was symptomatic. And so, where from my end, and I've seen patients, and I'm sure you have too, where they have a calcium score done and they ended up with like a score of thousands or even 2000, like really high, and never have had a heart attack. And so
Yes.
I can't stress this enough is that, and we have many conversations about this, is the artery, it's a muscle, it's not a pipe, and how disease forms with one person is different than the other based on what you do for lifestyle, what you do for possible medication. So I'm going to take it to the next step here, and I'll get that. I'll find that picture of the calcium score too. But what happens, uh, when you actually fail the stress test, right? When you go and you get you go to the doctor and they do the check your cholesterol and all that fun stuff that way. But when you fail a stress test, it's it's showing. I just wanted to go right to this stage here of artery disease. It's looking for that plumbing problem. And now, if you failed the stress test, we don't necessarily want to take you to the cath lab anymore and find out and open that up. Can you comment on that part of it? Because there's a lot of trials that have come out to support that too.
Yeah, correct. In fact, I was involved in one of those trials when I was in Houston, Texas, at Baylor College of Medicine.
The courage
Uh,
trial you're saying,
the
right?
courage
Yeah.
trial. The courage trial show that not everybody that has symptoms, despite having a significant amount of blood flow problems in the arteries of the heart, needs to have a surgery, meaning a stent or an angioplasty. There's medication that can be used to ameliorate the symptoms, and if you do the proper things with nutrition, mild amount of exercise, you have to be careful with exercise at this point, but
Mhm.
exercise, meditation, specific supplementation that we can talk about, uh, you can revert or regress some of the plaque slowly, maybe a 9 to 10% regression, which is what we've seen. But again, if you were able to do this early on, it's better not to have plaque building up than to having to regress it. That's the whole point here.
Of
But
course,
if
yeah.
you're there, if you're already there, yeah, there's many things you can do, and they all have to do with lifestyle. As I mentioned, some medications can be utilized, some supplements can be utilized to try to regress that problem. So
Yeah.
absolutely, not everybody needs to have surgery.
And that's, I mean, that's what we do at the Hartford Clinic. That's what you're getting into, is the idea of understanding the biology of the artery wall to see why someone's gone into that side of things. And you talked about hormonal imbalances. You talked about, I know there's heavy metal aspects of things. There's metabolic health things that are going on. And so maybe you can comment quickly on the biology of the artery wall is a lot different with everybody else than, it could be and should be that way too.
It is a lot different, and everybody works in a different way. Imagine that you're looking at a structure that is three-dimensional, and we always put it in pictures like this or like mine that is two-dimensional, and it seems so simple, but in reality, if you were able to look at the artery flow, there may be some arteries that look like they're significantly obstructed, but the flow is normal. What determines the flow and the elasticity of a vessel ultimately is the endothelium, which is the most that one that you're
Yeah.
showing there is in contact with the blood. You guys see when we draw blood and we put it outside in a tube or on a desk or anywhere else, it clots in seconds. Why doesn't clot inside the arteries? And the reason for that is because we have an endometrium that is avoiding that from happening. Imagine these microcells that are surrounding by little hair-like structures called cilia, called microcalyx, that have nitric oxide. Nitric oxide, it is like the skin of like a trout, like a fish when it's wet. It's extremely slippery. That's the way it should be the arteries. If our level of nitric oxide goes down, then the vessel starts getting a little bit stiffer and rusty, and that's when plaque starts forming and eventually can rupture and give you a heart attack. So nitric oxide, if you never heard about it, is a substance that we produce inside our body, but it comes from nutrition. There's a heart attack forming there, a clot forming, as Dr. Fernandez is showing here. And usually we see that happening more so in those plaques when they're called soft. They're more rich in lipids and easier to break. But going before this, the production of nitric oxide is key. And it starts where? In the mouth. Wow. In the mouth? Wait a minute. Why? It comes mostly from leafy green vegetables,
Hmm.
red vegetables like beets and stuff like that.
Yeah.
And the mouth, when we start chewing those vegetables as the most common source of nitrogen, then it becomes nitrate. Then when we swallow and it goes into the stomach, as long as the pH in the stomach is below 2, it can become now nitrite.
That's
That
why gut health is so important, right?
that
That's
will
why.
we'll
Oh,
come back to that. That eventually is formed nitric oxide, and it is a gas. Nitric oxide is a gas. Therefore, it doesn't really exist in pills, capsules. Really, is not available.
mhm.
Uh, the production of nitric oxide goes down with our age. That's an aging process, unfortunately, but it goes down if we don't have a good pH in the stomach, if we don't have gut health, if we do not eat enough of nitrogen in our food, mainly coming from vegetables,
Yeah.
from good soil. Imagine those people that take Nexium, omeprazole, famotidine, Pepcid. Those are antacids, and there's very common in our patients taking those. Those raise the pH in the stomach and do not allow the nitric oxide to be formed. Therefore, eventually, those medicines, unfortunately, are going to be detrimental for cardiovascular health, among other things. So I
Hmm.
always tell my patients, if I do not fix your gut, I'm not going to fix your heart. If I don't fix your heart, sorry, if I don't fix your gut, I'm not going to fix your vessels. I'm not going to fix your sleep. I'm not going to fix your depression. I'm not going to fix your anxiety. Pretty much everything is done. So fixing the gut health, making it healthy, it's key. It's step number one. In my clinic, I always give this detox cleanse to my patient for 1 month,
Hmm.
along with very high diversity probiotics with some fibers, and I give them a specific diet,
Yeah.
very low to none in sugar, no sugar, nothing of ultra processed food. Everything that comes in a bag, in a box, in a tube, or whatever that has more than 3 or 4 ingredients is going to be processed food.
Hmm.
No vegetable seed oils. Those oils are pretty bad. The only oil that is okay is true, has to be true extra virgin olive oil, but if you rather eat it raw, perhaps cooking with it is not so bad, but it loses its benefits. Whereas using the other canola, Suezon, or what is the name of the name? Soybean oil, peanut oil, cotton oil, you name it. Those are bad even raw. And those were engine oils back in First World War. And then since they're so cheap and easy to generate,
And you
they
find that a lot in, when you go out to fast foods or even to
everywhere,
great
everywhere.
high-end restaurants. Like,
Correct.
we would go out to eat to the restaurant, we got to tell them how to cook the food for us and make sure they stay away from those oils because, you can go to a really fancy restaurant that you think you're paying a good meal for, but they're cooking it the wrong way. And I mean, we could probably have a whole conversation, and I know we're going to have
That's
many conversations in
that's
the
a huge
future,
topic. Correct.
with nutrition and stuff like that, because that's I think a really great big game that you're playing as well on that end of it. So I just wanted to I just wanted to get to that picture because I know you asked me to the calcium score. Is that the calcium score? To me, it's like a positive, negative, and if it's positive, it's like, okay, well, we definitely have artery disease going on, right? And if it's negative, it doesn't mean that there's no artery disease going on.
Correct.
It's just one test to show us positive, negative. And I agree, it's way better of a test to do on somebody than just doing a stress test because that's the whole thing. And I don't like the idea of sending people down the radiation like nuclear stress and angios and stuff like that on a preventative basis because that's not what we do anymore. And you talked about the courage trial. Well, a lot of trials have backed it up since like the fame trials and the orbiter trials and the ischemia trial that came out before COVID. Those are and it forced us to follow it. That's the funny part. COVID kind of forced us to do it, but we unfortunately, I know because I have a lot of friends that are cardiologists, we just went right back to what we were doing because that's how I was trained and that's how I was doing it. And so I guess my question to you is that what made you think outside the box? Because and no disrespect and saying this in a way, but cardiologists get paid very well to do what they do. But what makes you think outside the box? Like, what was the turning point for you?
It was multifactorial. It was a lot of things at the same time that got together and made me realize that I was not doing what I felt in my heart that was what I wanted to do in my life. And I thought that operating hard from the beginning, operating hard was saving lives and changing lives. And short of that person that is dying and you truly save his life, the other surgeries that I was doing, which was 99% of the time, you're not saving any lives. And you're not teaching anyone to change their life for the better. So I felt that I was misleading patients to believe that they had a new vessel because I put a stent, that they had new heart or new vessel because we did a coronary artery bypass graft, like an open heart surgery. So I felt that that was not what I really wanted to be doing. And even though they pay very well, as you were saying, um, it's more satisfaction what I do now. It's a different pace, and I enjoy it the most. Ultimately, we want to do what we feel is the right thing to do, when you enjoy the most, and what is your passion. And slowly through the new training, I ended up seeing cardiology, medicine in general, through a different lens, completely different lens. And that's what took me where I am, here, just trying to prevent hearts and trying to help people change their habits.
So going to the like we have the Canadian Cardiovascular Congress here, the American Society of Cardiology, and you go see your colleagues every year. One of my favorite, and I still go to it. I sit on the committees and the organizing committees for that as well. But it's the idea behind that is it's still following a conventional path. And one of my favorite things is the tales of the cath lab, talking about the what happens in the cath lab that goes wrong and stuff like that. Can you comment now as like, what do you talk to about these colleagues that are in that same mindset, that you were in, I guess?
I think we need people in the cath lab to take care of those acute emergency
Always,
problems.
always.
Perfect. That's key. We need those guys. But I think that overall, the majority of the cases that are done in the cath lab could be prevented. So I tell my colleagues that, but they are in a different mode of just opening vessels, and like I was. And let me tell you, there were my favorite cases, or second favorite cases, were those cases where the vessel doesn't exist anymore. It's like,
Hmm.
what the hell? There's no vessel. And
Yeah.
you inject the dye and you don't see squat. And now you're going to have to be the equivalent to flying with monitors, like if you were a pilot, flying by night with only your monitors, trusting that the vessel should be there, and getting in there, out, inside there, inside out, and trying to find where the vessel was to try to drill through it. I did a lot
Mhm.
of those cases. And at any time, those cases can have, unfortunately, complications. Now, if the,
Show this picture while you're talking because this is,
yeah, no
I
problem.
think, very
If the
pertinent.
risk,
Yeah.
if the risk is really worth it, then, and you need the vessel to be open, go ahead and do it. But if there was no major symptoms and you're running a risk for no major results, then I'm not sure that we can justify that. What we're seeing here on the screen, on our left side of the screen, as you're facing it, there is an angiogram with a lot of detail of those tiny little vessels that we can penetrate with small wires. On the other side, it's the true way we see them in the cath lab. We only see the big vessels, like that vessel in there where the catheter is, and the other vessels showing up. Imagine that one of those vessels was not seen at all, or exactly those one that you're pointing at. Then we trust there is, and we put a
Oh yeah,
wire.
when you flush the dye here, it just stops. You can't even see the rest of the vessel. That's what
Correct.
you're
It would
talking
be
about. Yeah.
just a stump, and
Yeah.
you trust and you know that it should be there. So you start poking around and trying to get penetrate. And a lot of times we end up outside the heart. I mean, that's reality. You fix it by putting another kind of stent and coming back and trying to reroute the way and find the right pathway that you should have. But so again, all of this can be prevented if
Mhm.
we do certain things, like hopefully you're taught there. I know what they do at the Hartford Clinic, but if you follow those advices, that's key, because we can talk about the whole day, we can explain what needs to be done, we can put the tools in your hands, but if there's no action from the patient, we're not going to go anywhere. We need to do that.
Yeah. And that's so important. I mean, I love I love the philosophy of what you're talking about, and I agree with you. And you do require cardiologists when you're having an emergency situation. I always talk about it in three different pillars. Like you got the structural pillar, which is valve problems, where when I talked about the valve surgery, I've shared my story, and you'll get that in my book coming out. It's almost going to press here in the next few days, so I'm very excited. But the idea is that the structural issues, that you need a cardiologist to fix that valve, right? And if you have an electrical
Correct.
problem and you have you need a pacemaker or an AICD or, an ablation therapy, and that's an emergent thing, then that's important in the electrical pillar. And then in the last pillar, the arteries, like a pipe, you need the plumber when you're having the emergency heart attack, but you don't need the plumber if you're not having it. And that's where the differential comes into play. And that's what you've been talking about for.
100%
Yeah.
precise, correct.
Yeah.
Let me give you just a little list. People may be interested on, okay, besides nutrition, besides exercise, besides high quality sleep, besides meditation, and some supplementation, what else can be done to regress the plaque or prevent heart attacks? And there's very few things.
Hmm.
There's few for example, high dose of garlic, whether it's natural, which sometimes people avoid it because it's too strong.
Yeah.
There's some aged garlic extract capsules that we can use. Matt Budov years ago showed that those simple supplement can regress plaque. The use of omega-3 needs to be high quality omega-3, can do that. That comes also as fish oil. Need to make
Hmm.
sure that it's good quality. Vitamin K2. Hardly ever talk about vitamin K2. Vitamin K2 comes in leafy greens. Uh, and a lot of times people don't like to eat vegetables and so forth. But we hardly ever check even the levels. Vitamin K2 has a lot of information about it. Another one is nattokinase. Nattokinase, it's a very important supplement that can be bought. Usually it's not expensive, that helps with circulation. And there's some data for plaque regression. Um, resveratrol is another supplement that we can talk about. Usually comes from grapes, maybe the grape skin, maybe the seeds, and it helps with inflammation and has
Hmm.
some properties with plaque regression. There's some herbal antioxidants ways that we can do that as well. And of course, there's medications. But medications, the reality of medications is that even the highest doses of statins and another kind of medication that we call PCSK9s, they only regress the plaque at the most at 9%, which I'm not sure that is a whole lot, but there's some, of course. So you need to talk to these supplements, therapies to Dr. Fernandez when you see him, his team, and make sure that you guys know exactly what to do with those and how to take them.
Yeah, I mean, we got all that stuff in the clinic, and then getting a little bit more personalized on the biology as to why you are where you are. And since you touched on the cholesterol, and I know there's going to be questions because people ask me to ask this, is that cholesterol does not cause heart disease. And when we talk about statins and we talk about PCSK9 inhibitors, I know there's a lot of cardiologists that have different perspectives on this side of things, but you know, I always talk about this because it's about understanding the pros, the cons, and the risks. Like the risk of taking a medication. So there's always a good thing of taking it, and there's a good thing of lowering it. But I think the key is, and this is where I want to really get across before you ask you there, is that the artery is a muscle, and you already talked about it. It's a live organism. It's not cholesterol that accumulates to this pipe, and you have a last, cheeseburger, and you end up with a heart attack. It doesn't happen that way. So can you talk about cholesterol very quickly? Because I know that question will come up.
Yeah, back in the 60s, Ansel Keys, a physiologist from Minnesota, said that high cholesterol and high lipids or fat cause heart attacks. And he wanted to really go out of his way to show that.
Hmm.
So he started doing some studies, and then he embarked on this big study called the 7 country studies. And he plotted a graph that showed that the countries with the most intake of fat were the ones with most heart attacks. But later on, years later, we found out that he started with 23 countries, cut down to 22 countries, 17, 15, and so forth, until he made the data fit what he wanted to show. So that's a fraud. But back then, nobody realized that.
Hmm.
Not only that, back in those days, there was some emerging data by Dr. Jotkin showing that sugar was the problem for heart attacks and not cholesterol. But then the Sugar Research Foundation hired Mark Hexted from Harvard and bribed him with the equivalent of today's $50,000 to show his study has come just up. It was for publication, and he was going to publish that indeed cholesterol was not the problem, fat was not the problem was sugar. But the
Hmm.
Sugar Research Foundation asked him to change everything, and he did. Back in 1999 or 2000, something like that, there was a big study in JAMA showing this evidence. So everything was twisted. Food companies got a hold of that and they jumped on board and they wanted to demonize cholesterol, and they did a great job. So we from there we started growing, talking about cholesterol. But turns out that cholesterol helps with anti-inflammation, helps with infections, and likely helps prevent cancer. So the problem is that if you start a problem in a vessel like plaque, potentially there's cholesterol deposits trying to ameliorate or decrease the inflammation. Therefore, when you go and see the vessel, you find cholesterol presence, but it was not from the beginning of the problem, rather to trying to fix it. So when my patients talk about cholesterol, I tell them, hey, wait a minute, let's talk about sugar. Hemoglobin A1C, which is this blood work that we do that
What's hurting the vessel?
give us the answer of how much sugar you had in the last 3 months. Let's talk about your insulin level, which tell us how much sugar you've been eating, lately. And let's talk about your triglycerides, which are closely related to the amount of sugar that you're eating and other things. Those give me an idea that whatever amount of cholesterol you have is going to be problematic, but just because of those, not because of the cholesterol. Now, another important evidence is this. If you go to any given hospital in the world and you go to the heart attack unit, 70%, that's almost three-quarters of people after a heart attack or before a heart attack had normal cholesterol. So it's not high cholesterol that causes heart attacks. Not only that, another landmark study in JAMA showed that in people kind of older, beyond 65, 70, the higher the cholesterol, the fewer heart problems, the longer the life they had, fewer infections, and fewer cancer cases they had. So I don't think that we understand yet everything about cholesterol, but just cholesterol level by itself would not mean that you're going to have a heart attack at all. And
Yeah.
would not explain it.
So I anticipate lots of questions, and I want to be candid your time. I know I want to kind of keep it into an hour, and there are a lot of questions coming through. So if you have any questions, feel free to put them in the chat box here, and we can go through them. But is coconut oil safe with or avocado oil? Maybe I'll let you comment on that.
Okay,
I think they have
cooking
higher
with
smoke. Yeah.
coconut oil, I think is safe. We
Hmm.
have information about that. Cooking with butter is quite safe. Real butter, not margarine. Margarine is the opposite. Okay,
Yeah. Yeah.
it's it's a oil that was made margarine, so that's bad. Avocado oil, I think the data that we have is very limited. So I would
Hmm.
be very, very careful with avocado oil. I would not use it to cook. I think that if you're gonna eat it in a raw way, perhaps it's okay, as well as extra virgin olive oil in a raw form. But I would not cook with those guys if we could avoid it.
I know iodine is a big thing, and iodine deficiency, can help, can hurt, arrhythmias and hormone function. And so, how's it influenced with heart failure with iodine?
Well, iodine, the first probably organ that is going to be involved is going to be thyroid.
Hmm.
And we don't measure iodine on a routine basis, even though we could. And then years ago we had ionized salt. Now it's not ionized anymore. So I think I taking iodine as a supplement is very important to try to prevent thyroid issues. That eventually thyroid issues can translate into any other organ problems, including heart. Even heart failure can be from iodine deficiency.
Yeah.
So too much iodine can be harmful. Nothing could be harmful. So just a fine point in between. There's these drops of Lugol liquid. I take a few drops on a daily basis here and there. And I use ionized salt at home.
Hmm.
Um, Himalayan salt tends to have more minerals. I think also it's something that should be included instead of regular salt.
Yeah. No, for sure. Can you comment on high LPA? Like what are the good treatment options for high LPA?
Okay, so LP, we call it LP little a, but let's call it LPA. It's a lipoprotein that is associated with LDL. Now, when we talk about LDL, we always call it the bad cholesterol. But there's 5 molecules of LDL, even maybe more, but we know five.
Hmm.
Number one, two, three, five. Number five and number four are not that bad at all. They tend to be bigger molecules, more buoyant, and they don't really cause problems. One,
Yeah.
two, and three tend to be the problematic ones. So if you know your triglyceride level, you're going to know which kind of molecules you have. Obviously, you can check those with several different labs and see which ones you have. But triglycerides can give you a good idea. HDL and triglycerides together can give you a good idea. Now, LP little a or LPA is attached to the LDL. And
Hmm.
if we have different kinds of LDLs and sizes, we also have slightly different sizes and kinds of LPA. We know that when LPA is higher than 75 or maybe higher than 100, does it increase risk for heart problems? We know that, but we don't know why. We do not really know why. And the problem with LP little a is that it's pretty much hereditary. The number hardly changes any, and there's no way to really decrease it. Perhaps there's some ways to decrease it. Niacin helps, but it's difficult to take it because not everybody can tolerate it. It is just a vitamin. Niacin, I take 250 milligrams, but I've been taking it forever, so I can tolerate it now. Uh, but it can give
You
you
can ramp that up to get to that level that you need to.
slowly up
So,
by
yeah.
your guidance. If everybody was interested,
Yeah.
aged garlic extract can help you decreasing lipoprotein A, but there's no therapy that is consistent to lower it. So in people with high LP little a, as we know, it's hard to bring it down. I would
Hmm.
just be very careful or more careful to try to make sure that you decrease triglycerides to increase HDL, and that comes along with everything that we're discussing. Nutrition, do not eat the oils, vegetable seed oils, good sleep, meditation, supplementation, and everything above. Now, there's some emerging therapies for LP little a that we do not know what's going to happen with those. Remember, 25 years ago, there were emerging therapies to increase the so-called good cholesterol, HDL, that when they went to trials, they kill people. They increase HDL, but they kill people. No, not anymore. We don't use them. We're not even going to try them right now. So we have to be careful with those medications.
Yeah. No, for sure. I'd be dismissed not to ask the interventional cardiologist, how long does a heart stent last?
Oh, God, I'm 57 and I remember the days where we did not even have stents. It was just a balloon, plain, we call it POVA, plain old balloon angioplasty,
Yeah.
that they lasted minutes, hours. That's it. You had to come back for another one. Then the stents, just like little metal tubes that you open up, came on board, and those lasted months. Some of them lasted years with proper therapy. And then the next generation came with medication in the struts of the stents,
Yeah.
and those are the latest now. They've gone through different medications like rapamycin and so forth, and those last years. Potentially speaking, they can last longer, but that's not the solution to the problem.
Hmm.
The problem is this. We always think about a stent like if we were putting a stent all over the heart, and that's not the case. Let's say that we have a hose, garden hose, and let's say that it's 5 meters long or 7 feet long, whatever. And we have a problem in the middle. Okay, let's put a stent. We open up the middle. But this is not a hose, this is an artery. And this is a
And it
systematic
contracts.
problem that is happening all over the body. Because if you are creating plaques somewhere, you're creating plaques in all of the other arteries, some more than others. So you're not going to be doing a full metal jacket. And also, these metals is a foreign object that the vessels try to shrink, and they also try to get it out. That's why we use medications for that not to happen. You don't want a foreign object if you don't need it in the body.
Hmm. I know we could probably talk about that question all day long, how long a heart stents last. And it's like, I think the big thing I always talk about it is that these arteries are not pipes, they're a muscle. And, when you put in a stent, I mean, I've seen them last like, days, which is not good, or weeks, and people come back in with problems, and I've seen them last years. It just depends on, again, how someone addresses the foundation as to why they ended up with that problem in the first place. So I know we can talk.
Correct.
Yeah.
If I may, there's a question here about Mediterranean diet.
Yeah, absolutely. Yeah.
Trisha. So, look, that's a nice question. That's an important question because when you hear diets, you talk about Mediterranean diet. You also talk about what is it, low fat diet. You talk about keto. Uh, and there's so many names for those. I don't like names except for the Mediterranean, but we need to define that very well.
Hmm.
My diet is this: very low sugars, meaning carbohydrates, and very low to non-fructose. High in vegetables and high or good enough amounts of healthy protein with its own fat. Healthy fats are important. Mediterranean comes from the Mediterranean, and in that it's a different soil and they have different ways of agriculture. Okay, so be careful with that. But this diet is going to have a high amounts of vegetables, protein, mostly fish, but they also have some other meats. Um, and they are going to be heavy or high in grains, but there's our healthy grains. Unfortunately, in the United States, and I guess Canada is similar, we
Hmm.
have a lot of pesticides, herbicides that are making some of our grains not healthy. For example, oatmeal. Oatmeal, we like oatmeal. We always hear that it's good. I don't like oatmeal at all. I tell my patients not to eat it because if it's an oatmeal coming from the United States or surroundings, it's going to be high amounts of carbohydrates. And next one is going to be a lot of glyphosate and other bad chemicals involved in it. But a true Mediterranean diet done the proper way with a small amounts of red wine, absolutely. In fact, if we were going to line up all of the diets that we hear or we have heard or we know by names,
Hmm.
Mediterranean diet is the only one that has shown plaque regression.
Yeah.
But be careful. You need to do it right. If you're gonna get a sourdough, you're gonna get any bread, Ezekiel bread, and so forth. That's not part of a true Mediterranean diet. So be careful with that.
Yeah, that's important. There's a good question here. I skipped a couple there. Is explain the role of development of collateral arteries. How does that come into play? I know we do external counterpulsation therapy, and so I think that might be the question where it's coming from.
Okay, so but the question is,
Where's the
what is
role? What's the role and what's the role and the development of collateral arteries?
okay? So when we talk about the heart vessels as three major vessels, okay? Let's call it the right and two on the left side, and one on the left side is in the middle. So those three are the main ones. and they have some branches that we can see, but most times we cannot see the capillaries. We cannot see them in the cath lab. But when one of those vessels is obstructed, then then these other vessels that have some blood flow, because the heart needs oxygen, it starts
Yes.
generating some transmitters of new vascularization, which means we're trying to find new ways for the blood to flow. So imagine the muscle of the heart that is not getting blood asking for blood. And eventually we open tiny channels called collaterals. On the left side of our screen, we can see these are not true collaterals, but they look exactly like the collaterals will look if you were able to see them in the cath lab. And you don't see them unless they're a little bit larger than the true vessel. So the capillaries are usually not seen, but when they open up to try to get oxygen to the air, heart is not getting oxygen. Now we call them collaterals. So what is the role? Well, they can keep the muscle alive, but we call it hibernating, meaning the muscle is alive, but it's sleeping like a bear, and they're not doing anything and it's not pumping. So now when you talk about collateral, remember that I said that I like to open vessels that did not exist. If I was able to get into a collateral and follow the wire, it'll take me to the vessel that I cannot see, but I know is there. So those were my friends when I was doing heart operations to get into those vessels.
Hmm.
But you don't want collaterals if you don't need them.
Yeah.
If you have collaterals, we're talking that we're not doing a good job preventing anything.
Yeah. Well, and then someone who has advanced stages of a disease, that's where I always talk about like a highway system. If you close the 10-lane highway system gradually and it happens over time, you can have a heart attack, but you may not even know it. And so that's
Correct.
you probably would have formed those collaterals, and that's where the importance of collaterals comes into play,
Correct.
that way too. So I just want to be cautious of your time. You okay for a few more questions?
Yeah, yeah. Let's go
Yeah.
for a couple more.
So there was a lot of good questions here, so I wanted to go through them. Is it good to check, hormone panels, all thyroid panels, and checking for ferritin levels in the blood? Can you talk about the
When it
benefits?
comes to thyroid, my rule is to check the beginning. We check everything talking about TSH, free T4, free T3, TPO, and a couple more of the antibodies against thyroid, like antithyroid globulin.
Yeah.
Let's say that everything comes back normal, then I'm happy. But let's say that something comes back abnormal. If it's the antibodies, I know that this patient has had thyroiditis, which means a little bit of inflammation in the thyroid. That
Hmm.
doesn't mean that the thyroid is not working well. It can be working perfectly fine, but it's inflamed.
Yeah.
So we work in the gut to fix that problem, not in the thyroid. Okay. So ferritin, a heavy load of ferritin is a problem for any organ, including the heart.
Of course.
But I do not routinely check it unless I see an elevation in the hematocrit, that's the red cells, or the hemoglobin, or if I see that this patient has a heavy family history of a problem called hemochromatosis, then I want to know what his ferritin is.
Yeah.
But routinely, do not check that. And then supplements for thyroid. I don't know specifically which one you're talking about, but we talk about iodine. And I think that a small amount of iodine on a daily basis, it's important. And follow periodically the thyroid function. If you don't have the antibodies that you mentioned at the beginning, you don't have to check those for a long time, maybe 5 years or so. Just follow the other parameters, TSH, 53, 54 with your physician or Heart Fit Clinic or whatever you feel comfortable doing that.
Yeah. I know there's a question, how do you measure gut health? I mean, there are a lot of gut health testing that we can do at the clinic, so I can go through that a little bit later. By the way, for any of you that are onto this call, please, the idea of this call is to make sure that you get questions answered. And if they don't get answered here, every one of you is invited to come into any of one of our clinics, do a free consultation, understand what we can do to help you. We can connect you with different people. We got great access to great physicians. And so, so just want to be clear that if you, after today's call, if you're interested in this stuff, this is what we do really well at the HeartFit Clinic. So, we're good at connecting things on that side of things. There was a good question. I think you kind of alluded to this, 6-year-old gentleman, active, very high calcium score, very high cholesterol. Obviously, the cholesterol, the focus from a cardiologist to prevent it is just take a statin, because both parents died of that treatment. He doesn't want to do it. So anyway,
Perfect.
told that both his parents died from heart
Podcast.
disease only, and that's why. So can you comment on that?
Yeah, of course. When you talk about prevention, most of the traditional cardiologists, like I was 12, 13 years ago, we're going to talk about statins. And there's a lot of trials, in the past. And there's some prevention coming from statins that is very minimal, extremely minimal. Let me see if I can give you an analogy here. If I have 100 patients with a sore throat, meaning an infection from pneumococcus, from a bacteria, and I give them, I'm going to do a trial to see if penicillin works.
Yeah.
I have 200 patients, 100 I give penicillin, and the other 100 I give placebo. Okay, and then we open labels, and oh my God, one group, 99 or 100% of them got cured. On the other side, 20 or 30 got cured. Why? Because the ones with penicillin got cured.
Okay.
So the question is,
Well, empty it
how
out then.
effective-
Sorry, just 1 second there. If you guys can make sure you mute yourself, and maybe my staff, if you can make sure that everyone's muted there, please. Thank you.
So then you ask yourself, how effective is penicillin? Oh, it's perfect. It cures. You treat one patient and you cure one patient. That's a number needed to treat. One, you cure one. Perfect.
Love
I
it.
wish all the medications were like that, but that's not the case. So let's come back to the statins. If somebody with a previous heart attack, with another cardiac problem or stent, takes statins, how many do I need to treat to prevent a problem? It's in the range of 350 people. In other words, I need to treat 350 people to see the benefit in one of them. That's a very bad statistic for me. But if I treat people that never had a heart attack, meaning they're lower risk, the number needed to treat perhaps is 500. So how many people are we really benefiting by taking a statin, and why? And the answer is very few. And the other one is this. There's a study, I think the name is Jupiter.
Yeah.
Jupiter studies show that in people with normal amounts of cholesterol, normal levels, they were treated with a statin, and the other half of the group with placebo. Rosuvastatin, and this was the statin utilized, prevented some heart attacks, but it prevented it because it decreased inflammation. So there's a little effect anti-inflammation coming from statins, and perhaps their minor benefit may be coming from there. But omega-3 fish oil is anti-inflammatory. Garlic extract is anti-inflammatory. Resveratrol that we mentioned is anti-inflammatory. A very high intake of vegetables with fiber and Mediterranean in diet is anti-inflammatory. Meditation is anti-inflammatory. And there's other things coming, like, I bought this little collar like this that I put around my neck, and it gives me vibrations to the vagus nerve, anti-inflammatory effects. I've been using it for the last couple of months now. I love it. It increases the tone of the parasympathetic system, which is another big topic. And it helps you decrease anxiety, stress, burnout, tiredness, sleep better, you name it.
Yeah. No, I know we could talk about this all day long and stuff. I know there's some questions about C15, and if you're interested, I think we can go off on we're going to actually do a separate webinar talking about C15. So if you can
You bet.
some great people are going to talk about that. So I'm going to hold off on that question and stay tuned for a really great webinar on talking about C15. So I look forward to talking about that with you guys. So I'll save you that question there for now. But I know there was, what about whole plant diet without adding salt, sugar, and oil? What are your thoughts on that? I think it's very similar. That's the idea of a Mediterranean diet anyway, right? So
A whole, I mean, if you're going to be like a vegetarian, is that the meaning of it?
yes, yeah.
Okay. I think look, every time you need to supplement the diet, that means that it was not complete. So if you really follow a true Mediterranean diet with good amounts of protein and the vegetable, you perhaps don't need anything to supplement it with. Uh, so a true vegetarian diet, I do not go along with it. I have no problem if they want to do it for like a month or 2 months or a certain amount of time, but just vegetarian, I don't like it. The same as what is the other one that has no animal protein whatsoever?
Yeah, there's a few out there, and
Yeah, I forgot the name anyway.
yeah,
I don't go with that.
no,
And good source of an animal fat that is healthy is a good fat. It's a healthy fat.
yeah. So I mean, we can talk. And I'm gonna bring you back when you got your program ready, and I'm really excited about introducing this side of things. Um, there's questions how to get off statins. This is what we focus on in the clinic. You got to find out the biology of the artery wall. Like it's not just cholesterol that causes the problem. And so, as Dr. Oscar talked about, is that the idea behind this is to, start with your gut, right? To get to
You
improve your
have to
gut
start
health
there.
and start with your mouth health and all that part of it from that side of things there too. So, all those things are very important. Sorry, I just want to make sure everyone's muted there still. Um, thanks, guys. And thanks, team. And the idea is that all of this feeds off into different things to be able to help people understand what we can do to understand cardiovascular health and what we can do to help people prevent and even reverse cardiovascular disease. And so this is the stuff that we're doing. And I just want to be cautious of time today just because this is we could talk to you all day long, and I know there's lots of things, and I know we're going to be meeting quite a bit often afterwards as well. But I want to thank you, obviously, for your time today. I think again, leaving this webinar, you have the opportunity to do that consultation with us at the HeartFit Clinic. There'll be an evaluation and some stuff that you'll get as a follow-up from this webinar. So again, thank you very much, Dr. Oscar, for your time. I loved our conversations over dinners and the time that we had together there. It was very valuable. And, it's nice to see eye to eye on understanding this cardiovascular health because it's against the norm, right? It's outside the box. And this is where it's nice to see people like you making a change in the world. And I love to see that helping people prevent and reverse heart disease. So thank you very much.
No, it's my pleasure for being here. Thank you for inviting me.
Yeah.
Be ready to talk to you guys again whenever is needed, and have a healthy life.
Yes. Thank you very much. We'll be in touch again. So thank you very
Thank
much.
you.
Everyone have a wonderful evening, and thank you very much for all your time and attention today. I really appreciate it. And thank you, Dr. Oscar, for being here for us. Thank you.
Thank you, guys, everybody. Bye bye.
Okay. Take care.
Bye bye.